Hi everyone. Am I audible and visible? Hi everyone. If I'm audible and visible, can I see a thumbs up please on the live chat? Yeah. Good evening Surya. Good evening Akhtar. Good evening Gokul. So this is part 4 of Biochem Pearls for FMGE and NEET PG 2023 aspirants. Hi Krishnendu. So before we start the session, so in this session I've chosen few NEET PG 2022 questions and NEET PG 2021 MCQs. And using these MCQs, I'll help you understand many facts and concepts. Okay, so stay with me for another 45 minutes. And in these 45 minutes, I'll help you understand as many facts and as many concepts as possible. Okay. So before we start the session, let me tell you few facts about Unacademy's plans. So what we have released currently is NEET PG Vitals, and this will, if you get a subscription for NEET PG Vital, you will get an access to recorded videos. So long Unacademy has always been live sessions, right? Now you have an access to recorded sessions as well. So there are 3 subscription plans that we have now. One is NEET PG Live, the next one is NEET PG Vitals, and then combo package. So depending upon what you prefer, you can choose your subscription. And for getting a subscription, you can use any educator's code. If you want, you can use my code, which is my name, C Shanmugapriya. And currently this is a release offer which is available for 13,500. And phase 1 we have released many subjects including anatomy, physiology, biochemistry, ophthalm, SPM. And phase 2 would be medicine, pathology and microbiology. And phase 3, good evening Subha. Yes, and phase 3 would be surgery and anesthesia. And currently in the live session, we are conducting NEET PG Final Summit Batch. Hi, Dr. Bean. Thanks, Ravi Kumar. So now currently we have NEET PG 2023 Final Summit Batch. Module 1 is over, emergency room, wherein we discuss many clinical case-based MCQs. And module 2 would be frequently forgotten volatile topics. And module 3 would be most expected questions, wherein previous year questions will all be discussed. And for getting the subscription, again you can use my code. And we also have MBBS Prof subscription. Prof 1, for 1 month it would cost you 1,349. MBBS Prof 2 is also available. That is available at a cost of 1,799. Yeah, thank you all. So now this is the first question. You have taken the subscription, good. So this is the first MCQ for today evening. This is about Warburg Effect. True about Warburg Effect is, this is NEET PG 2022 MCQ. Can you all try answering this? Makes neoplastic cells immortal. Aerobic glycolysis with lactate formation produces more ATP, decreased glucose uptake. What do you think is the right answer? House MD says it produces more ATP. So do you all know that Warburg effect is all about neoplastic cells using glucose through aerobic glycolysis? And if a cell uses glucose through aerobic glycolysis, do you think the number of ATP that is produced will be more or less? Will it be more or less? It's going to be less. So this does not produce more ATP, because we know fatty acids on oxidation will give you more number of ATPs than glucose on oxidation. So when you know neoplastic cells preferably use glucose through aerobic glycolysis, the number of ATP production is not going to be more, it is going to be less. And it does not make a neoplastic cell immortal for sure. Okay, and it does not decrease glucose uptake, it actually increases glucose uptake. So what is the right answer here? The right answer here is choice B, aerobic glycolysis with lactate formation. So I'm going to tell you few facts about Warburg effect. Please listen to this carefully. What is Warburg effect? It is all about neoplastic cells metabolic machinery reprogramming itself to use glucose through aerobic glycolysis. So what does neoplastic cell preferably use? It uses glucose through aerobic glycolysis. Usually what is aerobic glycolysis? Glucose will go through glycolysis, it becomes 2-pyruvate, and then both the pyruvate will get converted to acetyl-CoA, and then acetyl-CoA enters into citric acid cycle, totally giving rise to 32 ATPs. This is aerobic glycolysis. But in neoplastic cells, in Warburg effect, when neoplastic cells use glucose through aerobic glycolysis, citric acid cycle does not happen. So pyruvate will not be able to get into citric acid cycle, and pyruvate will get converted to lactate. So without citric acid cycle, because glucose is being utilized, glucose gets converted to 2-lactate. So why do you think this happens? All of you, can you try answering why do you think this should happen at all? For 3 reasons. Because you know neoplastic cells are very smart. So they try to utilize something which will help them in their survival. So why do they use glucose through aerobic glycolysis? For 3 reasons. The first reason is the rate of ATP production will be faster. This is not the number of ATP that I am talking about. It's about the rate of ATP production that will be faster if it's glycolysis, because you know in glycolysis it's all about substrate level phosphorylation, so you'll get directly ATP. That is one advantage. The second advantage is when glucose goes through aerobic glycolysis, many intermediates would accumulate, and those intermediates can be used as building blocks by rapidly dividing labile cells, which are neoplastic cells. For example, in glycolysis, we get 3-phosphoglycerate that can be converted to serine. And serine can be used as a building block by rapidly dividing labile cells. So that's the second reason why neoplastic cells preferably use glucose through aerobic glycolysis. Now, when glucose is being used by a cell, GLUT transporters will get upregulated in neoplastic cells and hexokinase will become active. So more and more glucose will be trapped as glucose 6-phosphate within neoplastic cells, and some of these glucose 6-phosphate molecules will get into HMP shunt. When they get into HMP shunt, that acts as a source of NADPH, and this NADPH can act as an antioxidant mechanism, protecting these neoplastic cells from the oxidative stress that can be caused by cancer chemotherapy or radiotherapy. Another protective mechanism that is happening here. Do you all understand this? House MD, what is your question? Byproducts used in other pathways. So it is not about, yeah, almost right, you're right, House MD. The byproducts will be used as building blocks. 3-phosphoglycerate can become serine, and many of the intermediates can be used for protein synthesis. And the third reason is NADPH that is generated can protect neoplastic cells from anti-cancer drugs. Okay, so that is why your good evening pilot. And that is why neoplastic cells preferably use glucose through aerobic glycolysis without citric acid cycle. So glucose gets converted to 2-lactate. And this is why ketogenic diet can help or can prevent the progression of cancer. So why is ketogenic diet prescribed in a person with neoplasia? What is ketogenic diet? It is low carb, high fatty diet. It is nothing but low carb, high fatty diet. So how does low carb help? Without carbohydrates, glucose availability in the person's system will be less. So cells will not have an access to their preferred fuel, which is glucose. So neoplastic cells will not be able to survive. Now what if the person is on a high fatty diet? Excess fatty acid will be converted to acetyl-CoA. This acetyl-CoA will react with oxaloacetate to form citrate and ATP. So when a person is on a high fatty diet, fatty acid will be oxidized to form acetyl-CoA. Acetyl-CoA will be converted to citrate and ATP. And don't you know that citrate and ATP inhibits phosphofructokinase 1, the rate limiting enzyme of glycolysis? Don't we know that? You know that, right? Citrate and ATP inhibit phosphofructokinase 1. This is called as Pasteur effect. So please remember, what is Pasteur effect? It is nothing but citrate and ATP inhibiting phosphofructokinase 1. So if anybody is on a high fatty diet, glycolysis gets suppressed, and that does not allow neoplastic cell to survive. And that is why ketogenic diet is supposed to help a person with neoplasia. Okay? Yeah. So tell me, what is the right answer here? I want all of you to answer this now. True about Warburg effect is, does it make neoplastic cells immortal? No, it has got nothing to do with the mortality of neoplastic cell. Aerobic glycolysis with lactate formation is true. It does not produce more ATP. It actually produces less number of ATP, but the rate of ATP production can be faster. And it does not decrease glucose uptake. It actually increases glucose uptake. Yes, the right answer is choice B. Now the next question. True about telomerase or telomeres. Aging is associated with increased telomerase activity. With aging, telomeric length is gradually decreased. Telomeres have coding sequences. Telomerase is present in somatic cells. What do you think is the right answer? Rishabh says it's choice B. Others please. Krishnendu also thinks it's B. Gokul B. Subha B. Very good. Yes. The right answer is with aging, the telomeric length is gradually decreased. Okay. Yes. So I'm going to tell you few facts about telomeres and telomerase. First about telomeres. What is telomere? It is nothing but the terminal end of a chromosome. And what is chromosome? The one chromosome which you draw with a centromere, a short arm and a long arm is nothing but one long double-stranded DNA which has got condensed with the help of proteins. Do you understand this? Every chromosome is a long double-stranded DNA which has got condensed with the help of proteins. So what is a telomere? Telomere is the terminal end of a double-stranded DNA. So if you take one end of a double-stranded DNA, this end will have a 3' end and a 5' end. Kindly reduce the thickness of the font size. Yes, I can do that. Okay. So suppose you are looking at this end of a chromosome. This end of a chromosome will have a 3' end and a 5' end. Okay. So when DNA polymerase starts elongating new strands during replication, when DNA polymerase starts elongating a new strand, your DNA polymerase needs a primer to be already present. So first a primase synthesizes RNA primer and then DNA polymerase will synthesize a DNA strand. And this DNA polymerase will be proceeding progressively towards the other end. And it is not going to come across as RNA primer that is left back in the terminal. Which means following replication, when you get two daughter DNAs, in both the daughter DNAs, one of the two strands will be old. Yeah, in both the double-stranded DNAs, one of the two strands will be old. The other one is going to be new. And in the new strand, one of the two ends will be replaced by RNA fragment. One of the two ends will be replaced by an RNA fragment. And this RNAs are highly labile. Do you know that RNAs are more labile when compared to DNA? So in due course, this RNA will be lost. And that is the reason for telomeric end shortening. So the take home message for all of you is, during every replication, when you get two daughter DNAs, in both the daughter DNAs, one of the two strands will be new. And in the new strand, one of the two ends will be replaced by RNA fragment, which is labile, which gets lost. So as and when cells get into replication, the telomeric end will get progressively shortened. But there is a critical or a minimum length of telomere that is necessary to maintain the stability of your chromosome. So when you are born, you will be born with a particular telomeric length. As your cells get into replication or cell division, the telomeric end will get progressively shortened, but there is a critical or minimum length of telomere that is necessary to maintain the stability of your chromosome. Okay, and this is associated with aging and death. Do you understand this? This is associated with aging and death. Until when do you think a person can be young? A person can be young only until the person is able to replenish his or her losses. But what happens at one point? At one point, all your cells' telomeric length would have reached that critical length or minimum length, beyond which the cells will not be able to get into cell cycle. If cells do not get into cell cycle, they will not be able to replenish the losses, and that causes aging and death. Do you understand this? Telomeric length is related to aging and death, and this is why, have you heard of Dolly? What is that you all know about Dolly? Can anybody answer me? What have you heard of Dolly? Dolly is the first somatic cell cloned animal. Do you all know that? It's the first somatic cell cloned animal. And the difference between somatic cell and germ cell as far as telomeric end is concerned is germ cells have telomerase activity. What is telomerase? Telomerase is a reverse transcriptase. That is, it is RNA dependent DNA polymerase. So based on the RNA fragments that is left back after every replication, a telomerase can synthesize and supplement a DNA strand. Do you understand this? Following replication, when RNA fragment has replaced something, when there is telomerase, telomerase is a reverse transcriptase. It is RNA dependent DNA polymerase. So based on the RNA fragment that is left back, your telomerase can synthesize and substitute a DNA strand. And this telomerase activity is present in germ cells. It's not present in somatic cells. And what is so special about Dolly? Dolly is the first somatic cell cloned animal. And the difference between germ cell cloning is very good. Rabiha, Sheikh, excellent. Yes, cloning sheep, all of you are right. So the difference between somatic cell cloning and germ cell cloning is, germ cell cloning is like you're being given a clay, you're trying to give it a shape. You will not be very sure of how it would turn out to be. Whereas if it's somatic cell cloning, it is like you have been given a dried clay. All that you can do is you can use this dried clay as a mold and you can create exact replicas out of it. Do you understand the difference? Germ cell cloning is you have been given a clay because the genome is very naive. When you replicate that germ cell, you will not know how the product would look or how the product would behave. Whereas if it's somatic cell cloning, if you are taking somatic cell of a person, in that somatic cell, the genome has got folded to give rise to that person. And if you are cloning that somatic cell, the final product would exactly look and would exactly behave like the person from whom the somatic cell has been taken. So that is the difference between somatic cell cloning and germ cell cloning. And Dolly is the first somatic cell cloned animal. I'm not sure of the breed of sheep this Dolly belongs to, but that breed of sheep is expected to live for 12 to 13 years. But Dolly died at 6 years. Yeah, Dolly had just half the life expectancy. Why do you think? Of course, it died because of pneumonia. It had a natural death and it died because of pneumonia. Why do you think Dolly had just half the life expectancy? It is because Dolly was cloned from a somatic cell which was obtained from a sheep of age 6 years. Do you understand this? Dolly was cloned from a somatic cell which was obtained from a sheep of age 6 years. So that somatic cell telomeric end would have already undergone shortening of 6 years duration. So what do you expect Dolly to have? It can undergo telomeric end shortening for the remaining 6 years. That is why somatic cell cloned product has lesser life expectancy. So this is one hurdle which we are falling short of as far as somatic cell cloning is concerned, apart from the ethical issues which are attached to it. So have you understood all about somatic cell cloning and germ cell cloning and about telomeric ends? So let me quickly give you a recap. What is telomere? Telomere is the terminal end of a chromosome. This is nothing but terminal end of a double-stranded DNA. During replication, after every cell division, when you look at the two daughter DNAs, in both the daughter DNAs in the new strand, one of the two ends will be replaced by RNA fragment which is very labile, it gets lost. And this is the reason for telomeric end shortening. But there is a critical or minimum length of telomere that is necessary to maintain the stability of your chromosome. So once you see that all your cells have reached that critical or minimum length of telomere, you'll stop sending the cells into cell cycle. And this is associated with aging and death. Germ cells have telomerase, which is a reverse transcriptase, which is an RNA dependent DNA polymerase, which can replace the RNA fragment left back in the terminal with DNA. And this telomerase activity is present in germ cells, absent in somatic cells. And that is why somatic cell cloned product has lesser life expectancy when compared to the person from whom the somatic cell has been taken. Okay. So that's all about telomeres and telomerase. Okay. So tell me the answer for this question. Aging is associated with increased telomerase activity? No. With aging, telomeric length is gradually decreased. That is true. Telomeres have coding sequences. No, because your nature, because nature knows that telomere is subjected to shortening. If telomeres are provided with coding sequences, your nature knows that after every cell division, daughter cells will undergo gene loss, which is detrimental. That is why telomeric ends and centromeric regions are provided with non-coding sequences. Okay. So this is false. Telomerase is present in somatic cells is false. It's present only in germ cells. So this is the next question. I chose this question principally because many of you were asking me doubts about type of mutation. And this also happened to be a question that was asked in NEET PG 2022. So let's try to understand the answer. So Gokul says it's nonsense mutation. Shubha says it's missense mutation. Many of you are answering it as nonsense. Yes, very good. So the answer is nonsense mutation. Okay, answer is nonsense mutation. Apart from this, what are the other types of mutation that you can think of? Can you type that in the chat box, please? What are the other types of mutation that you can think of? Have you heard of transition? Yeah, transversion, substitution, point mutation, insertion, deletion, acceptable mutation, partially acceptable mutation. So there are so many types of mutation. And I'm going to clear all your doubts related to all these types of mutation. We have so many types of mutation only because mutation can be classified at 3 levels. In the first level, you classify mutation depending upon what happens to the nucleotide sequences. The second level, you classify mutation depending upon what happens to amino acid sequences. Third level, you classify mutation depending upon what happens to the function of a protein. Okay, so first level, depending upon what happens to nucleotide sequences, you can classify mutation as point mutation and you can classify it as point mutation and frame shift mutation. So tell me, what is point mutation? Point mutation is nothing but substitution, transition, transversion. Excellent, Subha. Yes, you're right. So point mutation is otherwise called as substitution. So what is point mutation? Because of a mutation, if one nucleotide is substituted by another, that is called as point mutation, otherwise called as substitution. And depending upon what kind of substitution has happened, you can classify point mutation as transition and transversion. So what is transition? As many of you have answered it, transition is wherein a purine is replaced by a pyrimidine. No, transition is wherein a purine is replaced by a purine or a pyrimidine by a pyrimidine. And what is transversion? In transversion, purine is replaced by a pyrimidine or vice versa. So these are the 2 types of point mutation. Okay. Now what is frame shift mutation? Whenever there is a loss or gain of nucleotides, please understand, whenever there is a loss or gain of nucleotides, the entire frame of reading might get shifted from that place, and that is called as frame shift mutation. If there is a loss, you call it as deletion. If there is an addition, you call it as insertion. So what are the 2 types of frame shift mutation? Deletion and insertion. So this is first level of classifying mutation depending upon what happens to nucleotide sequences. First you have substitution, the other one is frame shift mutation. Substitution or point mutation can be of 2 types. One is transition, the other one is transversion. In transition, purine is replaced by a purine or a pyrimidine by pyrimidine. In transversion, purine is replaced by pyrimidine or vice versa. Frame shift mutation is of 2 types, insertion and deletion. Now second level, depending upon what happens to amino acid sequences, you can classify mutation into 3 types. Those 3 types are silent mutation. The first type is silent mutation. Then you have missense mutation. Finally, we have nonsense mutation. So silent, missense and nonsense. So what is silent mutation? In spite of there being a change in the nucleotide sequences, if amino acid sequences remain unaltered, that is called as silent mutation. Do you understand the point here? In silent mutation, there is a change in nucleotide sequences, but there is no change in amino acid sequences. When will that happen? This is based on degeneracy of codon. What is degeneracy of codon? It means we have more than one codons which can code for a single amino acid. Don't you all know that? Yes, you have more than one codon which can code for a single amino acid. So because of a mutation, if a codon coding for one amino acid is replaced by another codon which codes for the same amino acid, then amino acid sequence will remain unaltered, and that is called as silent mutation. What is missense mutation? Because of a mutation, if a codon coding for one amino acid is replaced by a codon coding for another amino acid, and if amino acid sequence gets altered, then that is called as missense mutation. And what is nonsense mutation? Because of a mutation, if a codon coding for an amino acid is replaced by a stop codon, and if there is premature termination of protein synthesis, and if a truncated protein is produced, that is called as nonsense mutation. Do you all understand this? So that's about nonsense, missense and silent. So what is silent mutation? If there is no change in amino acid sequences. Missense mutation, when there is a change in amino acid sequence. Nonsense mutation, if a codon coding for an amino acid is replaced by a stop codon, and if there is premature termination of protein synthesis, that is called as nonsense mutation. Now the last point, or the last level, depending upon what happens to the function of a protein, how do you classify mutation? This is classified as acceptable mutation, partially acceptable mutation and unacceptable mutation. So the last level of classification of mutation is depending upon what happens to the function of the protein. It is acceptable mutation, partially acceptable mutation and unacceptable mutation. What is acceptable mutation? Here everything has happened. There is a change in the nucleotide sequence, because of which there is a change in amino acid sequences as well, but the function of the protein remains normal. If the function of the protein remains normal, that is acceptable mutation. What is partially acceptable mutation? There is a change in the nucleotide sequence, there is a change in amino acid sequence, and function of the protein is also abnormal. But if it's not immediately life-threatening, then that is partially acceptable mutation. So what is unacceptable? If it's immediately life-threatening, that is called as unacceptable mutation. So are you all clear about this? Yeah, we have acceptable when the function of protein remains normal. Partially acceptable when function is affected, but if it's not immediately life-threatening. Unacceptable if it's immediately life-threatening. So now I will give you few examples. Example for acceptable mutation will be all hemoglobin variants which are accidental finding on electrophoresis or chromatography. Yeah, have you heard of hemoglobin Milwaukee? Hemoglobin Milwaukee, hemoglobin Bristol and Sydney. This was asked once in NEET PG. So hemoglobin Milwaukee, Bristol and Sydney, all these are accidental findings on electrophoresis. Otherwise, oxygen carrying capacity of the hemoglobin will be perfectly normal and the person will be perfectly normal. That is called as acceptable mutation. And in all these cases, what happens? Usually 67th amino acid of beta globin chain. Yeah, 67th amino acid of beta globin chain is usually valine. And if that is replaced by aspartic acid, that is called as Bristol. The mnemonic that you can have is AB. Aspartic acid is Bristol. If it's replaced by glutamic acid, it is Milwaukee, GM. Glutamic acid, it is Milwaukee. If it's replaced by alanine, that is Sydney. In spite of there being changes in amino acid sequences, oxygen carrying capacity of all these hemoglobin variants is perfectly normal. So what kind of a mutation is this? That is called as acceptable mutation. So tell me, what is the difference between silent mutation, acceptable mutation? Silent mutation is completely silent. Even the amino acid sequence is normal. So even on electrophoresis or chromatography, you will not find any difference. It's completely silent. That is silent mutation. Acceptable electrophoresis or chromatography will tell you that there is something abnormal about the protein in this case, but the person is perfectly normal. Okay, so that is acceptable mutation. Okay. Example for partially acceptable mutation will be sickle cell anemia. So why am I saying sickle cell anemia is an example for partially acceptable mutation? Because only after dehydration or only after deoxygenation of hemoglobin, there is crisis. Otherwise, it's not immediately life-threatening. So it is included under which category? Partially acceptable mutation. Example for unacceptable mutation is congenital methemoglobinemia. Not only carrier state Gokul, even the sickle cell disease state, only after dehydration, only after deoxygenation you observe crisis, right? So it's not immediately life-threatening, so we include it under which type? Partially acceptable mutation. And then unacceptable if it's immediately life-threatening, example will be congenital methemoglobinemia. Okay, wherein oxygen cannot be carried by hemoglobin at all. So that is an example of unacceptable mutation. Okay, so that's all about types of mutation. I hope it's clear to all of you. Try to answer this. When a codon is converted to a stop codon, the type of mutation is, what is the right answer? The right answer is nonsense mutation. Okay, this is an interesting question which I chose, though it has got a physiological basis. I chose it because all these come under biochemistry, right? So rice water diarrhea, what is the right answer? Rice water diarrhea is cholera. Cholera is caused by a specific toxin acting on which of the following? Very good, excellent. Yes, the answer is GM1 ganglioside receptors. Yeah, cholera toxin acts on GM1 ganglioside receptor. So before I start telling you about how cholera toxin works, so I'm going to use this MCQ to tell you about what is ganglioside, what do you mean by GM1, GD1, and I will also help you understand how cholera toxin works. Okay. So what is a ganglioside? Ganglioside is a glycolipid. All of you please memorize it. Ganglioside is a glycolipid. And all glycolipids are derivatives of ceramide. Okay, when ceramide gets attached to a monosaccharide, you call it a cerebroside. Do you know that glycolipids are of three types? Cerebroside, globosides and gangliosides. Try to understand what is cerebroside, what is globoside and what is ganglioside, because it's being frequently asked whenever they ask you about glycosphingolipidosis. Okay, so what is a cerebroside? If ceramide is attached to just a monosaccharide, that is called as cerebroside. Example, ceramide is attached to glucose or galactose. So glucosyl ceramide is a cerebroside. Galactosyl ceramide is a cerebroside. Whereas if ceramide is attached to an oligosaccharide, that is called as globoside. Example is ceramide is attached to glucose and galactose. When ceramide is attached to glucose and galactose, we call it as lactosyl ceramide, which is an example for globoside. Now what is ganglioside? If ceramide is attached to an oligosaccharide with N-acetylnuraminic acid, that is called as ganglioside. So what is ganglioside? Ceramide is attached to an oligosaccharide with N-acetylnuraminic acid or a sialic acid, that is called as ganglioside. So example is ceramide is attached to glucose, galactose and N-acetylnuraminic acid. Yeah, ceramide is attached to glucose, galactose and N-acetylnuraminic acid is the simplest ganglioside, which is GM3 ganglioside. So all of you tell me what is the structure of GM3 ganglioside? Ceramide attached to glucose, galactose and N-acetylnuraminic acid is GM3 ganglioside. As complexity increases, the number decreases. So to this structure, if you attach N-acetyl galactosamine, that is called as GM2 ganglioside. If you attach N-acetyl galactosamine, that is called as GM2 ganglioside. To this, if you attach one more galactose, that is GM1 ganglioside. So what is GM1 ganglioside? This structure is GM1 ganglioside. So what is the structure? All these glycolipids, you start with ceramide. Ceramide is attached to glucose, galactose, N-acetylnuraminic acid is the simplest ganglioside, which is GM3 ganglioside. As complexity increases, number decreases. 2GM3, if you attach N-acetyl galactosamine, it is GM2. If you attach galactose, that is GM1 ganglioside. Okay, so here about the nomenclature, G stands for ganglioside, M stands for monosialic acid, M stands for monosialic acid, and the number 3 or 2 or 1 tells you about chromatographic migration. So what is GD? D means disialic acid. Instead of there being one N-acetyl neuraminic acid, if there is 2 N-acetyl neuraminic acid, that will be GD ganglioside. Okay, so this is an introduction to nomenclature. Have you understood this? Now, how does cholera toxin act? Cholera toxin acts on GM1 ganglioside receptor, and this GM1 ganglioside receptor is a G protein coupled receptor. Yeah, it's a G protein coupled receptor of GS type. So what have you learnt about all these G protein coupled receptors? Have you learnt that all these G protein coupled receptors have 7 transmembrane domains? They cross the cell membrane 7 times. That makes them look like a snake. And that is why you call these G protein coupled receptors as serpentine receptors. And these receptors have an amino terminal end and a carboxy terminal end. Carboxy terminal end faces the cytoplasm. C for C, carboxy terminal end faces the cytoplasm. And to this carboxy terminal end is attached a G protein. And this G protein has got 3 subunits, alpha, beta and gamma subunit. Now when I say it's a G protein coupled receptor of GS type, I mean to say the alpha subunit here stimulates adenylyl cyclase. Do you all understand this? GS means alpha subunit stimulates adenylyl cyclase. So listen to this carefully. In this receptor, generally on the 3rd transmembrane domain, there is a ligand binding site. Until there is no ligand, the alpha subunit is attached to GDP, which will be inactive. Once a ligand comes and binds to the ligand binding site, the alpha subunit will go and get attached to GTP. And this GTP bound alpha subunit dissociates from beta gamma. After it dissociates from beta gamma, because it is GS type, it stimulates adenylyl cyclase. And what will adenylyl cyclase do? It acts on ATP, converts it into cyclic AMP. And this cyclic AMP activates protein kinase A. And this protein kinase A in this case opens up chloride channel. Protein kinase A opens up which channel? It opens chloride channel. Let me give you another color. So it opens up chloride channel. That is the function of this GM1 ganglioside receptor. So what is the effect of cholera toxin? Listen to this carefully. What is the effect of this cholera toxin acting on this GM1 ganglioside receptor? The effect is that the alpha subunit loses its intrinsic GTPase activity. So that continuously the alpha is attached to GTP. Continuously what is produced? Cyclic AMP is produced. And which channel is open? Chloride channel is opened. Through this chloride channel, chloride oozes and that causes diarrhea. Because chloride is osmotically active, it attracts water, that causes diarrhea. So have you all understood this? So what is the take-home message here? The take-home message here is cholera toxin acts on GM1 ganglioside receptor. And this is a G protein coupled receptor of GS type. And the effect of cholera toxin acting on this receptor is that alpha subunit loses its intrinsic GTPase activity. So continuously alpha subunit is attached to GTP. As long as it's attached to GTP, it stimulates adenylyl cyclase. And that is why what is produced? Cyclic AMP is produced. And that opens which channel? Chloride channel is opened in cholera. Chloride is oozed out. Chloride attracts sodium. Chloride and sodium are osmotically active. They attract water. That causes osmotic diarrhea. Okay. So that's all about cholera toxin. Hope it helps you understand. So what is the right answer here? The right answer here is GM1 ganglioside receptor. So this is the next question, again a physiology based question, but I chose here because I want you all to understand few basic facts about neurotransmitter release, okay, and about how tetanus acts and how botulinum toxin acts. I hope you all remember that tetanospasmin causes spastic paralysis, whereas botulinum causes flaccid paralysis, right? So I'm going to explain that to you now. So mechanism of action of botulinum toxin is, what is the right answer? Dharamveer Prasad says it's answer D. Inhibits acetylcholine release from lower motor neurons, whereas Krishnendu says it's B. Inhibits acetylcholine release from upper motor neurons. So there is always a debate about this, right? Some of you think it's B, some of you think it's D. So I'm going to help you get clarified about all these doubts, okay? So for you to understand this, step number 1 is you should know what are the steps involved in neurotransmitter release. Yeah, listen to this carefully. By the end of the session, you will understand about steps involved in neurotransmitter release. You will know the difference between upper motor neuron, lower motor neuron. You will know the difference between how cholera toxin acts and how botulinum toxin acts. Okay. So what is the first step involved in neurotransmitter release? It is synthesis of neurotransmitters. So all these neurotransmitters get synthesized in soma or cell body. After they get synthesized in soma or cell body, by fast antegrade transport, these neurotransmitters reach the synaptic terminal. And in the synaptic terminal, there will be empty vesicles, and these neurotransmitters get taken up by these empty vesicles. After which there is translocation of these vesicles and they reach the synaptic membrane. And once these vesicles reach the synaptic membrane, a step called as docking happens. And what is docking? Docking is nothing but V-snare protein. V-snare protein of vesicle membrane docks with T-snare protein of synaptic membrane. And after docking, there is a priming step. After priming, neurotransmitters will be released. Do you understand this? After priming, neurotransmitters will be released provided an action potential gets generated in this nerve. Okay. And how do botulinum toxin and cholera toxin act? Both interfere with the docking step. Both cholera toxin and botulinum toxin act by inhibiting or act by interfering with the docking step. So both inhibit neurotransmitter release. Then both act by the same mechanism of action. How is it that tetanospasmin causes spastic paralysis whereas botulinum toxin causes flaccid paralysis? It is because of the difference in the neuron at which they act. So you will have to know the difference between upper motor neuron and lower motor neuron. Yes. So I am going to tell you what is upper motor neuron, what is lower motor neuron in a very simpler way. For you to supply nerve fiber to a muscle, yeah, suppose this is the muscle that you are trying to supply. From where will you begin the innervation? The innervation will begin with a lower motor neuron, and this lower motor neuron nucleus will be present in the tip of ventral gray horn of spinal cord. Yes or no? Up lower motor neuron, yeah, lower motor neuron or LMN. Where do you see its soma? The soma of lower motor neuron is present in the tip of ventral gray horn of spinal cord. And from here axon arises, that is called as lower motor neuron, and this lower motor neuron goes and terminates on the muscle fiber here. And what is the receptor here? The receptor here is NM receptor. NM receptor which is present on the neuromuscular junction. So what should be the neurotransmitter that acts on the NM receptor here? The neurotransmitter is acetylcholine. And this acetylcholine is released by lower motor neuron. And this lower motor neuron or alpha motor neuron is at what level? It is at the spinal cord level. Are you going to allow anything to happen at the spinal cord level alone? No. Everything should be under the inhibitory control of brain. So brain exerts its inhibitory control through upper motor neuron. And this upper motor neuron arises from the contralateral side cerebral cortex motor area. Yeah, upper motor neuron arises from the contralateral side cerebral cortex motor area, is characterized by large pyramidal cells called as bed cells. And projection of these bed cells form corona radiata. This corona radiata goes through posterior limb of internal capsule. It goes through midbrain, pons and medulla. Till the lower part of medulla, it is on the contralateral side. And in the lower part of medulla, this upper motor neuron decussates. And after decussation, you call it as ipsilateral upper motor neuron, which terminates on the ipsilateral lower motor nucleus. Do you all understand this? Yeah. So from where do you begin the upper motor neuron? Upper motor neuron begins from the contralateral side cerebral cortex motor area. Layer 5 is characterized by large pyramidal cells called as bed cells. Projection of bed cells from corona radiata. It goes to posterior limb of internal capsule. Goes through midbrain pons medulla. In the lower part of medulla, it decussates and comes to the same side. So now it is ipsilateral upper motor neuron, which terminates on the lower motor nucleus downstream. And I said this upper motor neuron is inhibitory. So what is the inhibitory neurotransmitter that is released by this upper motor neuron? It is glycine. Yeah, what does it release? It releases glycine. So how does tetanospasmin act? Both tetanospasmin and botulinum toxin gain entry into your nervous system through lower motor neurons. Both enter through lower motor neurons. But as soon as they enter into lower motor neuron endings, botulinum toxin inhibits the release of acetylcholine. Yeah, what does botulinum toxin do? It inhibits the release of acetylcholine from the lower motor neuron endings. No acetylcholine release, no muscle contraction, and what does it cause? That causes flaccid paralysis. Whereas tetanospasmin also gains entry through lower motor neuron, but after it enters into lower motor neuron, through retrograde transport, it reaches the soma of lower motor neuron. By budding mechanism, it gets released into the synapse and then it gets into the upper motor neuron ending. So tetanospasmin inhibits the release of what? Tetanospasmin inhibits the release of glycine from upper motor neuron ending. No glycine release, no inhibition of lower motor neuron. So lower motor neuron releases excess acetylcholine that causes spastic paralysis. So are you all clear about this? Yeah. So that is about the difference between tetanospasmin and botulinum toxin. So tell me, what does tetanospasmin inhibit? Tetanospasmin inhibits the release of glycine from upper motor neuron ending. Botulinum toxin inhibits the release of acetylcholine from lower motor neuron ending. Okay. So Krishnendu, is it clear now? What is the right answer? The right answer is it inhibits acetylcholine release from lower motor neurons. So this is the next question. I think most of you, I hope that most of you have attended my session, yeah, the plus class session, wherein I think we were discussing about this in emergency room. I told you exactly how to interpret arterial blood gas analysis report, right? So let me check how far you have understood this. Identify the acid-base disorder in a patient with the following values. Respiratory acidosis, very good. So what do you see here? pH, bicarbonate, PCO2. Before we start interpreting everything, let's recollect normal values. So all of you tell me, what is a normal pH? Normal pH is 7.36 to 7.44. What is a normal PCO2? For PCO2, take off the 7. What is remaining? 36 to 44 millimeters of mercury. And what is a normal bicarbonate? Normal bicarbonate is 21 to 27 milliequivalents per liter. Using these normal values, start interpreting the provided values. What has happened to the pH here? The pH is low. If the pH is less, what is your diagnosis, all of you? If the pH is less, it is acidosis. Now, how will you find out whether it is respiratory acidosis or metabolic acidosis? Any acidotic condition can be because of two reasons. One is a decrease in bicarbonate. The other reason is increase in PCO2. Why should a decrease in bicarbonate cause acidosis? Because bicarbonate is a major plasma buffer. So when you're missing the major plasma buffer, you will not be able to buffer acids, and that causes acidosis. Metabolic acids accumulate. So that is called as metabolic acidosis. Why should an increase in PCO2 cause acidosis? Because carbon dioxide is a source of an acid. Carbon dioxide forms carbonic acid. Because carbon dioxide is a source of an acid, for any reason if carbon dioxide accumulates, that causes acidosis, and that is respiratory acidosis. Yeah, with this background, can you tell me what is the right answer here? pH is low, which means it is acidosis. So we have excluded choice C and choice D. Now look at bicarbonate. I said normal value is 21 to 27. In this case, bicarbonate value is high. Can a high bicarbonate explain acidosis? All of you tell me, can high bicarbonate explain acidosis? No. If at all high bicarbonate is the cause of acid-base imbalance, it should have caused only alkalosis. So bicarbonate value getting altered is not the cause here. Now look at PCO2, normal is 40, here it is elevated. Can an increase in PCO2 cause acidosis? Yes. And what is it? It is respiratory acidosis. Is that clear to all of you? What is the right answer here? The right answer here is respiratory acidosis. Okay. And if you are asking me if it's respiratory acidosis, then why bicarbonate value has been elevated here? It is compensation. Yeah, it is compensation. So what is that you need to know about compensation? The compensation is always parallel. If the primary defect is respiratory, compensation is done by bicarbonate. If the primary defect is respiratory, compensation is done by bicarbonate and the compensation will be parallel. If the primary defect is an increase in PCO2, compensation will be an increase in bicarbonate. If the primary defect is a decrease in PCO2, compensation will be a decrease in bicarbonate. Here the elevation of bicarbonate is a compensatory mechanism. Got it? Yes. So this is respiratory acidosis. So the next question, this is a NEET PG 2020 question. So NEET PG has a affinity. It has an affinity to ask affinity for acid-based questions. Okay. So please be very clear about interpreting ABG reports before you attend your exam. Okay. So pH, tell me what has happened to the pH here. pH is low, which means it is acidosis. So this is not metabolic alkalosis or respiratory alkalosis. Look at bicarbonate. Normal bicarbonate is 24. Here the bicarbonate value is low. Can a low bicarbonate explain alkalosis? No. So this is not metabolic condition. Now look at PCO2. What has happened to PCO2? PCO2 has decreased. What am I saying? No. I'm sorry. So low pH is acidosis. Acidosis is accompanied by a decrease in bicarbonate. Can a decrease in bicarbonate explain acidosis? Yes, it can explain acidosis because you have missed a buffer. So what is it? This is metabolic acidosis. Okay. So the answer here is metabolic acidosis. Okay. Now another acid-base question asked in the same NEET PG 2020. The question was, a 55-year-old male presents with tachypnea and mental confusion. Blood glucose is 350 milligram per deciliter. pH is 7, which is too low. Bicarbonate is 18, which is low. Urine shows presence of ketone bodies. So even if you don't know to interpret ABG values, the moment you see ketone bodies, what will you tend to answer it as? The moment you see ketone bodies, you expect diabetic ketoacidosis, and you know diabetic ketoacidosis will cause metabolic acidosis. So just based on history, your answer would be metabolic acidosis. Let's try to find out if it's right. Okay, pH is low, so it is acidosis, and bicarbonate is low, so yes, it is metabolic acidosis. Clear? It is metabolic acidosis, and had they given you sodium, potassium, chloride and bicarbonate values, you can calculate anion gap. And diabetic ketoacidosis will be a cause of increased anion gap. It will be a cause of increased anion gap, metabolic acidosis. And if you're asking me why is the person tachypnic? Yeah, it is because whenever there is metabolic acidosis, the acid pH will stimulate the respiratory center and the person hyperventilates, and this is a compensatory mechanism. Because when you hyperventilate, you wash away carbon dioxide, a source of acid is gotten rid of. So that will to some extent combat the acidosis that is caused by accumulation of ketone bodies. And that is why in metabolic acidosis and diabetic ketoacidosis, what is the breathing that you observe? The breathing that you observe is Kussmaul's breathing. So what is the reason for Kussmaul's breathing? It is because acidic pH stimulates respiratory center and the person hyperventilates. It's a mechanism, it's a compensatory mechanism for metabolic acidosis. Okay. I am telling you all this because many students, as soon as they saw tachypnea, they didn't even bother to read about the remaining statements. Tachypnea, hyperventilation, they answer it as respiratory alkalosis. And the take home message for you all is just based on history, do not choose the choice. Okay, many a times they try to confuse you like this. Okay, so try to find out if it's right by looking at all these values. To interpret ABG report, all that you need to know is 3 values: pH, bicarbonate, PCO2. Just find out what is a primary acid-base disorder. From there you will be able to proceed further. Okay. So this is the last question for today. The mucopolysaccharide that is present in glomerular basement membrane is, I think I've already told you this in one of the biochemistry Pearl session. The mucopolysaccharide that is present in glomerular basement membrane is heparin sulfate. Very good, Krishnendu. Answer is carbon dioxide can only dissolve in blood-brain barrier. How come unmeasured anion H+ can stimulate? Okay. So whenever there is acidosis, whenever hydrogen ion accumulation happens, metabolic acidosis, it utilizes bicarbonate, right? And whenever bicarbonate gets utilized, the equilibrium gets shifted in such a way that the hydrogen ion gets accumulated in the CSF also. Because the reason for hydrogen ion accumulation CSF is carbon dioxide. Do you understand that? Yeah, it is principally because of the shift in the equilibrium between bicarbonate and carbon dioxide that carbon dioxide accumulates and carbon dioxide forms hydrogen ion, and that stimulates the respiratory center. Okay, so answer here is heparin sulfate. And let me tell you about location of mucopolysaccharides quickly for those of you who have not attended my session previously. So what are the mucopolysaccharides? First, it is hyaluronic acid. Hyaluronic acid is present in synovium and in vitreous. One second. This is zooming. Yeah. It is present in synovium and in vitreous. And where is keratin sulfate type 1 present? Keratin sulfate, keratin stands for cornea. So keratin sulfate type 1 is present in cornea. Keratin sulfate type 2 is present in loose connective tissues. Okay, type 2 is present in loose connective tissues. Heparin is a natural anticoagulant that is secreted by mast cells. I hope you all remember that. Heparin is a natural anticoagulant that is secreted by mast cells. Heparin sulfate, just now I told you, is present in glomerular basement membrane. It is also present in large vessel wall like aortic wall. These are the 2 places that you should remember as far as heparin sulfate is concerned. It is present in glomerular basement membrane and aortic wall. And then chondroitin sulfate. Chondroitin stands for cartilage. So it's present in cartilages and bones. Dermatin sulfate, it's a misnomer. Just because it's dermatin sulfate, don't think it's present only in skin. It has got the widest distribution. Okay, it is present in every tissue. Yes, it holds lipoprotein lipase. Very good, Gokul Kamath. So that's all about location of mucopolysaccharides. So where is hyaluronic acid present? Synovium and vitreous. Keratin sulfate type 1 is present in cornea. Keratin sulfate type 2 is present in loose connective tissues. Heparin, anticoagulant released by mast cells. Heparin sulfate is present in large vessel wall like aortic wall. It's also present in glomerular basement membrane. Chondroitin sulfate is present in cartilages and bones, and dermatin sulfate has got the widest distribution. Mucopolysaccharide structures. Okay, I can tell you about mucopolysaccharide structure. Tomorrow, please attend the session. I will introduce 2 to 3 MCQs on mucopolysaccharide structure, and I'll help you understand it. Okay, tomorrow same time, 7 o'clock. Okay, so answer for this is heparin sulfate. Okay. So thank you all. See you tomorrow at 7 p.m. That will be part 5 of Biochem Pearl, quick revision session. My pleasure, awesome doctor. See you all.